كوفيد اليمن 2020 باثوجينيسيس اند كلينيكال برزنتيشن، الحاله السريريه مع المرضى. بناء على المرضى اللي شفناهم، الحاله السريريه في حالتين، جزئين تنقسم: اكيوت لانج انجري، اصابه في الرئه، اكيوت لانج انجري بلس ثرومبوسيس. إصابة في الرئة وتجلطات. من فين جت هذه الاثنين؟ الفيروس كوفيد 19 يصيب الرئة في البداية، يصيب الرئة، يحفز جهاز المناعة. يصيب الرئة، يحفز جهاز المناعة، يحفز السيتوكين. في معانا نوعين من السيتوكين مهمين جدا في الحالة المرضية على ضوء الحالات اللي شفناها. IL-X انترليوكين 6، الثاني انترفيرون جاما. هذا في غاية الأهمية، هذا اللي بيعمل لنا ثرومبوسيس. هذا بيعمل لنا ليفر انجري بسبب كوفيد 19. Interferon gamma also will do tumor necrosis. This also rise in COVID-19, and tumor necrosis still not know. يعني كثير من علامات الاستفهام عليه. هل COVID-19 is human made or not human made? Why? Because this agent is will do tumor necrosis. هل هو intended؟ هل هو عمل كعلاج للتيومرز؟ استيل هذا إجابة السؤال هذا مش موجودة. بس from pathophysiology it is do tumor necrosis besides thrombosis that it is prominent. Okay? This symbol from pathophysiology is عميق وكبير جدا، لكن هذا السيمبل وبسيط جدا. تارجت شيئين، هدفه كان حاجتين: الاكيوت لانج انجري والثرومبوسيس. That we see in all patients, most of patients. Thrombosis not only in lung, it is most common in the lung. Thrombosis about 70 to 80% is in lung, but also in the cardiac, in the brain, in the renal. Okay, it is endovascular inflammation, endothelitis can lead. Okay, this is from point of pathogenesis. Next, على ضوء هذا الشيء، الشيء الثاني about COVID-19. The COVID-19 carried by human immunity or human body. In the early stage, COVID-19 is killed by cytokines and antibody, most prominently by cytokines. And the consequence of disease, it is due to the immunity. When we see the cause of clinical manifestation, the infection started here. The viral in day one, in day one, there is incubation period before. But in day one here, there is starting to replicate the virus. And then the virus go down. Maybe at 9 or 10 days in severe. Virus cannot be seen by human immunity. No drug that effectively kill the virus. Up to now, no drug that effectively kill the virus, except one thing, that is human plasma convalescent. Human plasma convalescent can do harm and can do benefit. If human plasma started here early, before viral replication or with viral replication, plasma can do fine, can benefit the patient. But if the convalescent plasma started here, when the virus go down and the immunity go up, immunity up, antibody here the virus go up and the plasma here it will harm. This proved by study. Prove the patient that given plasma and have antibody, it is do bad. The clinical manifestation do deteriorate. But if the patient given plasma and no antibody, the patient can be fine and benefit from the plasma. The plasma is one treatment that can be used in situation that epidemic and no drug or no treatment. Okay? And it means it can benefit the patient, it can harm. Other drug also can harm the patient. Example, chloroquine. Chloroquine, as we tell, no drug that kills the virus up to now. Chloroquine, early immune suppressed, can increase the viral replication. Late, it is immune suppressed. It can depress the antibody, late state. Can depress the antibody, but the problem with chloroquine, it is contraindication in patient with cardiac problem. The patient with cardiac problem, it is contraindicated to give chloroquine. Patient with COVID, it is underlying disease, it is sick. Even not patient have disease of cardiac. And so the chloroquine is harmful, and the study also proved that. Other drug, interferon gamma, interferon, A and beta, interferon. As we did before, the interferon, it is one part of pathogenesis of the disease. The interferon gamma, it is increased in the COVID-19. How I treat interferon and the patient have interferon? It is no benefit. Okay? This diagram is very important. Antibody, it is go up in the late stage and viral replication in early stage. And then finish it maybe at the 9 or 10 day in severe cases, or maybe late in the moderate and mild cases. Maybe viral remain in the body for 16 to 17 days in patient with up to 20 days in patient with mild to moderate. But in severe case, the virus it is killed by day 10 or day 11. It is not, and the studies or investigation came with many patients. It is COVID-19, proof COVID-19, but the test is negative. CRP is negative. Why CRP is negative? The virus it is go down. Early in course it can be positive, but late in course it will be negative. And in our protocol we add antibody test. Antibody test can help us in the late stage, that when the virus it is go down. Antibody test can help us in patient symptomatic, not patient asymptomatic. In asymptomatic may be found antibody test, but in symptomatic patient, in the wave of COVID-19, with symptomatic patient, antibody test can help us in the diagnosis of COVID-19, especially post 10 days. But in asymptomatic, no role for antibody test. Remember, the COVID-19 is killed by human body. No drug up to now it is killed. It is effective against COVID-19 except some plasma in specific time, not in course of the treatment or like in time. The time it is also important for treatment. I think no, up to now no one in the world speak about the timing. It is important in treatment. It's important. Next, our experience in Yemen. Our experience in Yemen. We start treatment early. First, the COVID-19 it is introduced to Yemen. Yemen no COVID-19 before. It is the last country. It is the last country affected by COVID-19. Okay? We start the treatment for COVID-19 early. First case that we start treat and save him life. First case was elder patient. It is complicated case. It is complicated. The first case, and it was very complicated case. It is in the 18 years. 18 years old. 18 years old, hypertensive, hypertensive, and diabetic. These patients get the virus from his son. The son of these patients, of this old age patient, it is from his son that was dead and suspected COVID. The son is dead and was the source. Is dead and source. In ICU. We offer the treatment for this son, and we contact with one doctor for contact with the doctor of this son, and the doctor refused the treatment. The doctor is refused the treatment because it is no WHO is still against the steroid. Okay? And the patient dead. We start the steroid in this elder and hypertensive and diabetic. This patient, it is dead in the worldwide, in the most country, in the developed country. This patient, it is dead. Hypertensive, diabetic, and elder. This patient, the family can prepare coffin for him. Because it is already dead, it's well follow his son. We start the treatment by steroid. Was methylprednisolone. 80 milligram BD plus anticoagulant. Okay? This patient, before I start steroid, was on antibiotic for 12 days. Different antibiotic for 12 days, but no benefit. I tell you before, it is no antibiotic kill the virus. Different antibiotic will not kill the virus. Different antiviral will not kill the virus. Up to now, every study approved this. Many studies approved this. No effective against COVID-19. Before I will do the treatment was started but not benefit. The patient deteriorate, and we start methylprednisolone and anticoagulation at day 12. The patient start improve after 2 to 3 days. Start improve, and the family not expect to improve after this course. The patient is alive. Up to now, it is 6 months. The patient is alive, no problem. The patient by 3rd day, go to his parking home as usual after the 3rd day. Up to 6 months after the treatment, we follow this patient. The patient is still alive, no other problem, no recurrent COVID-19. It's gets from this, it is the COVID-19, get the immunity from the infection, especially the patient with severe. Also the moderate and mild can get immunity. This was the first patient. It was big challenge. and the patient is survives. It survives. The next patient also was in 60 years old and diabetic. I select the patient, I start my trial in the most difficult patient. Most difficult patient, not here in the world. Patient next one is 60 years. 60 years and diabetic. And diabetic. 60 years and diabetic. The patient was hypoxic. As first one, it was hypoxic. This patient also hypoxic in the 80. Was the saturation in the 80. And start the treatment by antibiotic. Start the treatment by antibiotic for 5 or 6 days, but no improvement. No, for 11 days also. Start treatment for 11 days, approximate nearly less than 2 weeks, but no improvement, and the patient could deteriorate. After start the steroid, methylprednisolone, and anticoagulation. The patient, it is by third day also improve, and by 5th day it is not need oxygen. By 5th day it is not need oxygen and improve. Up to now it is 6 months for patient, approximate 6 months, the patient is alive. 1 point for this patient, it is patient also in aspirin. Aspirin, up to now, no one in the world speak about aspirin. Aspirin, it is also maybe have big role. Big role because the problem it is thrombosis. This patient also on aspirin, and we not stop the aspirin for these patients, continue on his aspirin. Okay, and both the recovery patient still in aspirin or continue aspirin. This may tell us the aspirin also have role in the treatment of COVID-19. Up to now, no one in the world speaking about aspirin. It is afraid from the Ray's syndrome. Ray's syndrome, worldwide afraid from aspirin, but the Ray's syndrome is really very rare. Rare and in pediatric. It can happen in adult, but it is in pediatric patient that can lead to Ray's syndrome, acute hepatic failure. Acute hepatic failure. I give you other hint for this. It is maybe better than paracetamol. Why? Because paracetamol will not reverse the fever of COVID-19. The patient with paracetamol can get more of paracetamol until develop acute liver injury. And it is big problem. The paracetamol is the most common cause of acute liver injury in the world. It is okay in pediatric. Paracetamol it is okay in pediatric because the pediatric patient can have different pathophysiology than adult. That names sulfation. It is high sulfation in pediatric that can detoxify the acetaminophen. But in adult patient, sulfation is out. It is adult patient is at high risk for acute liver injury than pediatric patient. And the role of acetaminophen, because the patient with fever, cannot get better with acetaminophen, and the patient will take another dose, until will reach to the acute liver injury. It is bad problem. If there is happen, it is acetaminophen. In acetaminophen is a treatment of choice. But we tell you other hand. patient in one transplant, liver transplant. He surveyed the patient. Percentage of the patient, it is taking the paracetamol in usual dose and develop acute liver injury. Not only overdose is the most common cause, but also patient with acetaminophen, if it in the usual dose, it can have been problem. But it is still, it is aspirin, it may be safe, but I put here as option to give the patient this aspirin. It can lead to Ray's syndrome, but the prevention of thrombosis, stroke, and acute MR, it is biggest than problem in acute liver injury. That is very rare, and the CDC also, it is remove the Ray's syndrome from reportable disease. It is one. It was one of the reportable disease. Ray's syndrome, if you see, can report to CDC. Now it is removed from reportable because it is rare there. But if there is cases Ray's syndrome in children. There is, I think, one conference is several cases of Ray's syndrome in children happen from Ray's syndrome. I would advise in pediatric patient, less risk, and asymptomatic patient, most of cases, and not advised for it, but also in the adult, it is option to give the patient option to be in the safe side. It is one option. Can take the drug. It is will prevent the stroke. It is will prevent the acute MR. From this patient is taken aspirin. Well, it is the second patient in our trial. The third patient, it is mother, and also was different story and story from her. She was live his husband to be ended. And كانت تطلب من زوجها انه يسامحها انها بتفرق. تمام. Also started in methylprednisolone and anticoagulation, and the patient alive up to now. These three cases. I select these first three cases. I not select any patient. This first drug over for these three patients, and the patient all alive, and up to now it is still alive, no problem, no recurrent COVID-19 for this patient. Follow his activity as usual. Okay. Then after these three drugs, we start to contact with other doctor in other. This case was in Sana'a. I start to contact with other doctor in Aden. It was Dr. Amr Turki. At that time, has one of family, two of his family is in COVID-19, and he started the treatment on his family, and he survived, one female and one male. One of his family كانت زوجته والثاني كانت عمته, and both survive up to now. Then the Dr. Amr Turki start to enforce this protocol in Aden, and was at that time it is mortality very high in Aden. Everyone in the world was here. It is very high mortality in Aden, not only from COVID, but also other problem was in epidemic, dengue fever, can also malaria. We see a lot of patients. Dr. Amr Turki refer to me patient COVID-19 and malaria positive, and start the treatment also protocol in one start in one hospital, the hospital that is starting in work, and see the patient. It is different than before. Before can was very high mortality. After starting treatment, decrease the mortality in that hospital, then start to disseminate to the other hospital, other isolation hospital, other hospital general and specialist hospital. It was consultation with Dr. Ahmed Turki and apply this protocol, and the mortality decrease in adult. This was summary in adult. We have cases, and Dr. Ahmed Turki sent me cases, a lot of cases. We will add it in this program for benefit for others. The protocol in Adam, it was different than our protocol, but we added the methylprednisolone to the treatment in Adam, and was successful in treat many cases. Other side, we contact with Dr. Akram Sharami Al-Mal. It is have one كان مركز isolation, director of one isolating center in Marib for COVID-19. Before I contact, he tell me a lot of patients he did. I tell him first, start steroid. I not give him any one steroid. And he was start on hydrocortisone, but he not see the improvement in hydrocortisone. I tell him to increase the dose of hydrocortisone. It can benefit the patient. Hydrocortisone, it was start and I give him another thing. If not start on hydrocortisone, it can start on prednisone. Prednisolone. And he start in prednisolone oral because the methylprednisolone is not available in market and it's very expensive. And start in prednisolone, and the patient, amazing improvement in the patient. And tell me first, I contact the second day, he tell me the patient is discharged to home. First patient start, the second day is discharged to home. It is amazing result. I start the steroid first one in Yemen, maybe in war. After me, the recovery trial, it is came from UK. Recovery trial came from UK till the dexamethasone, not methylprednisolone, not the methylprednisolone, the dexamethasone. It is life-saving treatment in severe case. But I tell the methylprednisolone and prednisolone, I try for many patients, also in patient with dexamethasone. Patient was in dexamethasone, the course of improvement is slowly with dexamethasone. Maybe the dose that start in the UK and approved also by WHO, the dose is slow and the improvement is slow. It will improve from any steroid, but the improvement is slowly. The dose slightly high, it is get very rapid result for improvement. The methylprednisolone, I think also some patient, I see patient in dexamethasone, also some patient afraid, his doctor afraid from methylprednisolone and prednisone and start on hydrocortisone. There is improvement also in hydrocortisone, but it is slowly the improvement. And we change in the treatment, may increase the dose of hydrocortisone or may change to methylprednisolone and get rapid recovery. Even with dexamethasone that seen slowly recovery, increase the dose of dexamethasone can also improve the recovery. This is real patient I see. This in mild improvement and survival improve. Other thing also in تواصلت مع other دكتور أحمد محمد سيف, and he tell me the patient that I send home the methylprednisolone or prednisolone to the home, it is alive. When the recovery start, when recovery trial came from UK, recovery trial, from UK and approved from WHO. I contact our doctor that as well as I contact him before. I contact with Dr. Ahmed Turki and Dr. Akram Shirabi and other doctors. At time of recovery trial appear and approve. After that, about 2 weeks or 3 weeks, the WHO approved that. He tell me no drug like methylprednisolone, it is effective. He will also try dexamethasone and other drug. The dexamethasone, not like methylprednisolone. Also, the prednisolone. Also, it is effective maybe as methylprednisolone and maybe better than methylprednisolone because it is oral. Oral treatment is very important in COVID-19. Why? Oral treatment is very important because any manipulation in the vessels, especially the central vessels, it is will exaggerate the mortality or increase the mortality because it will induct the thrombosis. Central line, it is nearly or relatively it is contraindicated unless it is necessary to do central line formation with COVID. Because patient baseline is thrombosis and the central line is one cause of most common cause of thrombosis. And so if the patient can take oral, it is best to take oral. IV cannot manipulate it unless necessary. Unless necessary. No drug effective against the COVID-19 to be giving IV. For exception one plasma, I will tell you before, it is also need timing. In treatment, need timing. It can be given early before the antibody can arise and late it will deteriorate the case. Another thing, patient now recovered. Patient now recover. What post-recovery? Post-recovery, can patient continue also on anticoagulation for some period? We start on some patient anticoagulation and some patient do INR increase the INR and stop the treatment, and still patient up to now alive, no problem. Post-recovery, ممكن anticoagulation to decrease pulmonary embolism, to decrease DVTs, to decrease maybe stroke, to decrease also maybe acute coronary syndromes. The duration is short, not need to be long. Short course, maybe 1 month at least, unless the patient is have DVT or B, the treatment or it is change maybe for long term need anticoagulation, the patient develop DVT or B, but as prophylaxis it is short course. Also, patient who cannot take anticoagulation or unitolerated anticoagulation, I think post-recovery aspirin is good. Aspirin is good to prevent the stroke and prevent acute coronary syndrome. Take home point. Methyl prednisolone or any steroid, short-acting steroid, or other short-acting steroid, or other short-acting steroid is life-saving. Is life-saving. 1 point here for short course. For short course, less than 10 days. But also we added 1 point here. If the patient inflammatory marker, it is decreased or decreased to normal, or patient COVID-19 is not induced inflammatory marker, I will not prefer to use steroid. Because it is the virus can behave other very rare behavior, you increase the infectivity of this virus without induction immunity, that the steroid may increase the replication of virus. But for immunity, the steroid is life-saving. That is the most cases that we say it is due to immunity, due to induction of immunity. Other point here, anticoagulation. For short course, prophylaxis, it can, for short course prophylaxis, it can also decrease mortality due to the consequence of thrombosis post COVID-19. Third, aspirin. It may have role. Role in decrease. In decrease, the consequence in decreased thrombosis and decrease in inflammation due to COVID-19. للأسف أحد القنوات العالمية عملت مقابلة مع أحد الطبيبات في عدن، وقالت إن the only doctor to treat the COVID is this دكتورة لا أذكر اسمها، لكن الحقيقة ليست هذا الشيء. الحقيقة أن أهل عدن بمن فيهم أطباء وغير أطباء قاموا ضد الكوفيد. قاموا ضد الكوفيد. بداية العلاج في البيوت، بدأ العلاج بالحالات في البيوت. أنا ساهمت في شيء واحد اللي هو إدخال الميثيل برنزولون إلى البروتوكول الذي أسسه أهل عدن. الذي أسسه أهل عدن. بدأنا في صنعاء على الميثيل برنزولون ونقلناه إلى عدن. كان دور كبير للدكتور عمرو التركي في التواصل مع معظم المستشفيات، ولم يكن فقط معظم المستشفيات بل أيضا تواصل مع مكتب الصحة في عدن، وقالوا له في البداية في أنهم سيدعموا بفحوصات لأجل هذا البحث. شيء آخر، الطبيبة التي قيل أنها الطبيبة الوحيدة التي تعالج المرضى في عدن، هي أيضا كانت تأخذ الاستشارات من الدكتور عمرو التركي التي تصل إلينا. وشكرا.
ابدأ.
اليوم موضوعنا ستروك. definition of stroke. Arterial obstruction that lead to ischemia and infarction manifested by neurological deficit. Okay. definition الثاني TIA. It can lead to neurological deficit, but the medium heart association without brain infarction. الكوز etiology thrombosis, embolism, this for ischemic stroke, maybe dissection, especially in trauma. Other time, hemorrhagic stroke. Intracerebral hemorrhage, subarachnoid hemorrhage, this second type. It is important as in ischemia, either in heart or in brain, it is the timing of ischemia. It is very important. Timing from stroke because on the timing is will decide the patient need antifibrinolytic or no, need TBA or no. If you cannot determine the timing, it is very problem and will be difficult scenario, and may need other things. But when determine the timing, early recognition of the stroke, it is very important. From point of the symptoms, it is neurological deficit. But it is also important to determine the arterial. The arterial affected. Either anterior cerebral artery, or middle cerebral artery, or vertebrobascular artery. Vertebrobascular artery. On clinical presentation, each one can have different manifestation. Example, anterior cerebral artery, it will affect the lower leg. Contralateral lesion. It will spare the face and hand. In anterior cerebral artery, spare the face and hand. Lower leg, as you know in the anatomy, the homunculus, it is supplied by anterior cerebral artery. The homunculus is for lower limb. The middle cerebral artery, there is two presentation for middle cerebral artery. First, affect the face, plus arm, face arm, more than leg. The second, the first also, in the left dominant, affect also aphasia. It can will lead to aphasia. Aphasia is two types of aphasia. It can be expressive and receptive aphasia. Receptive aphasia, that patient cannot understand what you tell him. And the expressive, it is the motor aphasia. The patient can understand you but cannot speak. This aphasia will affect the dominant hemisphere. In non-dominant, the patient can manifest neglect one part of the body. It is typical in the patient contralateral to the lesion. The presentation was face and contralateral to the side of the lesion. One important thing, it is the gaze. The gaze in the stroke, it can be toward the side of the lesion. If the patient has right side lesion or left side lesion, can affect the right arm and face, and the eye can deviate it to the side of the lesion in the middle cerebral arteries. Okay? The other presentation, the neglect when in non-dominant. The second part, it is when affect the internal capsule. The internal capsule, when affected, it can give us picture both upper and lower. يعني affected the face, arm and leg in the contralateral relation. When an internal capsule, because it is dense fiber came from small area, can affect it all. Another typical manifestation for middle cerebral artery or the hallmark is affect the motor as well as the sensory. It is one hallmark for middle cerebral artery. The vertebrovascular artery concentrate, it is well-known ataxia, dizziness, vertigo, the posterior circulation, but what we concentrate on one point also, loss of consciousness. Loss of consciousness when affected the brain stem. Other point, it is very important for example left cerebral artery, left posterior cerebral artery, left posterior cerebral artery, it is homonymous hemonopsia. Homonymous nopsia. Homonymous hemonopsia. What is this? In patient affected left posterior cerebral artery, if there is left side affected, the patient cannot see what on the right of the patient. Because it is affected the temporal and affected the nasal part here, the patient cannot see the right side of his patient, cannot see the right side. When affected left side, and the axe also when affected right cannot see what is on the left side. This left posterior cerebral. Another point is very important. It is large visual obstruction. Large visual obstruction. We'll come to this point later because it is important and decrease the improve the outcome when treated. And in the management, طبعا diagnosis need CT scan, non-contrast CT scan. Now this is the first step and the first choice, but now also after CT scan and after CT scan done and the TBA is done, can patient undergo to the perfusion scan will angio scan, CT angio or MR angio. Why? As we tell you before, the large visual obstruction. Patient undergo a non-contrast CT scan and receive TBA. After the TBA can undergo for this to detect large visual obstruction. If there is large visual obstruction, the patient candidate for thrombectomy. Because patient, if undergo TBA and have large visual obstruction and the thrombectomy is not done, the patient will stay in the bedridden or in the wheelchair and bad outcome will happen. This is also in the recent years added. This from point of diagnosis. Other test, very important test, blood sugar. Blood sugar, the only test that can be done before CT scan. The only recommended test that can be done before CT scan, unless the patient is coagulation or suspected bleeding diathesis, bleeding diathesis, they need also coagulation profile plus platelet, because this can change the management if suspected. But the blood sugar is the only test. What about the treatment? The treatment, start by recognition of stroke. Started at the public. When he can detect the patient in stroke, should be transferred immediately to the hospital. In the AMS has criteria for detect the patient in stroke. One criteria, it is named be fast. Be fast. Be fast. This used as criteria. There is also other criteria, but this criteria is used. These indicate balance. Is there disturbance in the balance? This eye, this is abnormality in eye, cannot see. This face, be it dropping or not dropping. This arm, left arm, less speech, have be aphasia or no aphasia. This T, it is time. Time to call, time to transfer. Okay? This help to early recognize the patient and early transfer the patient to the hospital. This from point AMS or pre-hospital. In hospital, as we told you before, clinical presentation of the patient, examine the patient, and determine the time from onset of stroke. Time from onset of stroke. There is several doors. If the patient has stroke and the time is determined, the door from the patient arrive to examination, it is less than 10 minutes. Less than 10 minutes للexamination, less than 10 minutes, less than 15 minutes للconsultation, less than 25 minutes للCT scan. CT scan, very important. Less than 45 minutes, less than 45 minutes for CT scan report. CT report. Less than 60 minutes for TBA. Secondary goal, less than 45 minutes. Secondary goal, less than 45 minutes, and can give the TBA أقل من 45 minutes. Okay. Added other thing, you less than 120 minutes. طبعا or equal. Less than 120 minutes for thrombectomy. Effluent vessels occlusion. This is new. It is important to keep in mind differential diagnosis or mimic of stroke. As we told you before, patient with total paralysis post-seizure can mimic the stroke, but it can be differentiated first by CT scan and patient with seizure can the affected gaze can be contralateral to the lesion, can be to the contralateral to the side of the lesion, but while the patient in the stroke can see to the side of the lesion. Example, the patient, I see him right lesion, I see him left side weakness. The patient, if stroke, will look to the side of the lesion. But if the patient on the left side weakness and he look to the other side, it is seizure. It is not stroke. Other thing from the mimickers, maybe electrolyte example, hypertension. The most important is hypoglycemia. Patient with hypoglycemia, should be treated first, and it is one inclusion criteria to start TBA, not starting patient TBA before the patient is less than 60. Other mimickers for ischemic stroke, if the patient sudden severe headache, it is indicate the patient subarachnoid hemorrhage and need evaluation for subarachnoid hemorrhage, because if give him TBA, this will be catastrophic. As we told you before, the timing is important. If the less than 3 hours and the patient candidate for TBA, no contraindication to TBA, can start thrombolytic. Less than 3 hours. In 3 to 4.5 hours, patient, there is special situation and inclusion criteria to start thrombolytic here. First, in the 3 hours, is the patient have measurable, first, less than 3 hours, measurable focal deficit. Measurable focal deficit, it means the patient has a stroke and still in stroke. And it is not TIA. Patient can, if the patient improve completely, it is not indicated for TBA. The second thing, less than 18 years. Was you before sugar أكثر من 60. This patient indicated for TBA. If other contraindication is not present, we have here was PowerPoint, but it's not working. The lab for 3 to 4 hours. Also indicated for TBA, but all in special situation. Patient not more than 8 years. Patient not more than third of MCA criteria, MCA territories. Patient not on anticoagulation. Patient not diabetic or recent stroke. If patient here not indicated or contraindicated, it can undergo to the thrombectomy. Other territories, other point, patient now less than, more than 3.4 ila 24 hours. This patient not need TBA, but patient can undergo thrombectomy. All these must be in consultation with neurosurgeon. The new approach for stroke to rapid treatment, it is start now some starting treatment the TBA in the CT scan, not the ICU, not any site, other site in the CT scan. Why? Because CT scan, in the CT scan, patient can give him TBA under monitoring, can give it TBA under monitoring post the CT scan is done. Why? To maximize the time, because every time, every moment aware, wait, for example, if there is neuronal loss, and to patient after TBA given can undergo for CT angio immediate at that time, and from the CT scan patient cannot return back to the ER, can go immediate to the cath to undergo thrombectomy, to undergo thrombectomy, and from the thrombectomy, after thrombectomy can go to the ICU without return